So can you make sure that you have your device on mute so that we don't get any background noise? Having spoken to Mr. Hussain and Mr. Joshi, if you have questions, could you please pop them in the chat function? Because I think we're going to have quite a busy meeting and they're going to take questions at the end. Please feel free to pop your questions in at any point. They might get covered during the talk, in which case I won't need to ask them. If you do have a burning desire to ask a question, please put your hand up as well if you want to do that. It would be good if you go on camera if you are going to do that. We are recording, so if you don't want to be seen, do switch your camera off. I think without further ado, I will hand over. Now, Mr. Hussain is going to be doing the lecture, but Mr. Joshi is also on the call and will field questions with Mr. Hussain at the end. So they're going to do a bit of a tag team on that. So if I can just introduce, there's Mr. Rahim Hussain and Mr. Shobin Joshi, who are both consultant neurosurgeons at University Hospitals Coventry and Warwickshire. So Mr. Hussain has recently joined us. Mr. Joshi has worked with us for a while now. So let me hand over. Are you ready, Mr. Hussain?
Yeah, thank you very much.
I shall mute myself and turn my camera off, and Vicky will manage the presentation.
Lovely. Thank you, Mel. Good evening to all. I'm Mr. Rahim Hussain. So I'm actually I've been working in the NHS for nearly 17 years. I started my first job back in London in Royal Free Hospital in 2005. And I worked further in Liverpool in Walton Centre and had my spine fellowship in 2006 and 7. Subsequently, I went to Wales to work in Swansea as well as in Cardiff for nearly 7 years before I moved to England into Coventry as a consultant back in 2016. So prior to coming to this country, I was basically trained as a neurosurgeon back home in India. And I worked in Kingston, Jamaica for nearly 7 years as a neurosurgeon, dealing with the complex neurosurgical disorders, right from pediatrics to adults, the trauma with the gunshots, everything. So I mean, I moved with that experience to this country, so it was very easy for me to settle in as a senior registrar role, and I was able to offer a lot of operations independently with the minimal supervision. So I was a bit lucky to come to this country with that experience and with that background. So I think we'll start without much delays. I think I was given the topic approach to back pain, which is, I mean, it sounds a very simple topic, but I don't think it is quite simple, because the reason I'm saying that is I've been quite used to teaching the medical students or the neurosurgical trainees, sometimes in our departmental teachings. I haven't been involved in teaching the general practitioners or mixed audience or allied healthcare professionals. So I actually don't know what their expectations are. I thought I'd just prepare in a very simple format and maybe take some questions to make it more interactive and more comprehensive. And my colleague, Mr. Joshi, is there to support us, and probably he can share his experience as well. So I just formatted the presentation into contents, which is basically we'll go for definition and a bit of background and statistics and types of low back pain and how you diagnose this and how you assess these patients, and what are the red flag conditions that you should be aware of, and also the management options and various the pathways. I think one important stuff that I would like to reiterate in this lecture is going to be the Get It Right First Time Spinal Services Guidance, because this is now there's a national awareness about the GIRFT for every specialty, because if you don't get it right for the first time, then there's an implication to cause more morbidity to the patient, and also there's a burden on the healthcare and etc. So I think now the thinking is whichever specialty you are in, if you're especially before you operate, and just get it right first time. So I think I will just touch some principles on spinal services relevant to back pain as well. Next slide, please. So low back pain, as you guys know, is basically any pain in the area of lumbosacral region of the lower back, and which can actually radiate into both buttocks, and sometimes it comes into the greater trochanter area, and it should not go upper limit wise up to the lowest rib cage. So that is a typical lower back pain, but you always have some sort of a overlap in the description of this pain by different patients. So I think you need to focus on hips, the sacroiliac joint area, and then the lumbosacral area in particular to define the lower back pain. So because there are specific conditions and specific pathologies that actually affect this part of the spine, so it's very important to narrow down to localize the pain so that you can start thinking about those conditions without missing any one of them. So there is no what we call a concrete data with regard to prevalence, because like people say, if you get the back pain, that means you're actually hitting 40 years of age. So you can actually presume that every one of us, when we hit 40 or above 40, we would have experienced some sort of a low back pain of various intensity in our lifetimes. So I think there is some figure of 20%. I don't know where it came from, but I think I found it in the one of the articles on the back pain websites. So apparently GPs see around 20% of the people with low back pain in their practice every year. I think it could be understandably a low number. I suspect they see more than this. So, and also the low back pain is one of the common symptoms, and it's also the largest single cause of loss of disability adjusted life years in England. This is actually, there's a report submitted by the GIRFT Spinal Services, so which is quite interesting. And I think it's also, you'll find a similar comment and a similar evidence even in the North American studies as well. So it's also a specific and non-specific causes of back pain, because people can just, because the pain is subject to symptom, and anybody can actually say, I got a pain, and mostly it is non-specific. But if they got a pain going into leg, then it could be a referred pain, or it could be a true pain affecting a nerve root, what we call radiculopathy. So when you have a back pain with a leg pain, it's more than likely to be a true symptom rather than a false symptom. So we'll just to come to that at a bit of in a later part of the presentation. So the back pain also got an economic cost. So it actually contributes to nearly 14% of all time off work. And if you look at the, I think there was a program on the BBC as well a long time ago, around 3 or 4 years ago, on back pain. So they actually estimated there's a significant amount of money is lost because of the loss of work as well. So both from the employer's point of view and as well as employee point of view. So in 2015 and 16, the back pain related working days in the UK was around 3.4 million days so per person, which is quite a significant productivity has been lost in the economy as well. So I'm going to be describing sciatica is a very common term people describe when the pain actually goes into the leg. And in simple terms, it's called lumbar radiculopathy. The reason why we call sciatica, which is quite a famous term to describe a leg pain, is because one, the pain is coming from the sciatic nerve, and the sciatic nerve has a root value of, I mean, for the sake of clarity, it actually got a root value of, is quite a chunky nerve coming from L2 up to S2. So it acquired a broad contribution of lumbosacral nerve roots forming the sciatic nerve. So any problem affecting the L1 root, L2 root up to S2 root can actually have some sort of radiation into the back of the thigh. Sometimes it's the upper part of the thigh, middle part, or maybe back of the thigh, back of the knee, or into the leg, or into the ankle, or into the big toe, or into the sole. So it depends upon which nerve is affected. So you can actually have. So I think in general term, it's called sciatica. And sciatica per se has no root value, because you have to take the history and you have to assess the level of distribution of the pain. Then only you can actually suspect which dermatomes or which roots are affected. So sciatica is a very colloquial term used by most of the people to describe leg pain. The most common causes that you encounter in clinical practice, I just go through examples as well, is the disc prolapse, what we call herniated intervertebral discs. And the next common is going to be the spondylolisthesis and spinal stenosis. And very uncommonly, you see infection or malignant deposits in the spine as well. Can you see that slide? I think I got a bit.
Sorry, Mr. Hussain. I think we're having a few problems with the slides. So which slide are you on at the moment?
Sciatica slide. It is moving, next one.
Right, okay. Has that changed for everyone?
It hasn't changed, isn't it?
No.
It has changed for me, you saying, Shabin here.
Oh, is it?
I've got the picture diagram showing now, yeah.
Yeah.
We are in slide number 7 now.
Is it me moving it? Because I just moved it now. It has gone to the next slide.
No, I think I'm moving it on.
We are on slide 7.
Fine. I think we are in the slide 7 now.
Okay.
Correct.
Fine. So this is just a diagram taken from the what we call radiology images website. So this is just to reinforce the anatomy of the disc and the relationship between the disc and the nerve roots as well as the spinal canal. So, which is the pointer here? I can't see the pointer. Can you see my mouse tip?
I don't think we can see your mouse because I'm sharing the slides at the moment. So,
okay, fine. So I think looking at the normal anatomy on the left side of the screen, so there's a cross-sectional area going through the vertebral body. So obviously you can see this is the upper end plate where you can see the white stuff is the disc, which is the soft gelatinous material, and then there's a thick ring, which is the annulus fibrosus. And it's quite a thick tenacious ring with a special cartilage, which actually contains the disc, which is the remnant of the notochord from the development of the what we call the spinal column. So, as part of the aging process, the strength of the annulus actually gets weaker, and the disc hydration becomes less and less. So, disc becomes dehydrated. So, as the tension within the annulus gets less, then it won't be able to withstand the stress and strain of the various spinal movements. Then it develops some cracks here and there. There are some genetic conditions which actually affect the health of the collagen, and in which case people will actually manifest with disc herniations at a very young age. But the typical age to have the disc herniation is going to be between from the age of 30s up to 50s or even up to 60s. And after that, it's very uncommon. And you can actually see here, if you look at the anatomy, the microscopic anatomy of the annulus, the weakest part of the annulus is actually posterolateral part and not actually in the central part. Hence, if the disc has to herniate for any reason, it actually tends to herniate posterolaterally, and you can see on the right side of the diagram, it actually catches the nerve in the foramen of that particular affected nerve. So the disc rupture centrally catching the the cardiac vena or the theca itself is uncommon, but it can happen as well. But the most common herniation is going to be the posterolateral, in which case patient will have a back pain with the one-sided leg pain, depends upon which roots are affected. Next slide, please. So this is the next condition called a spondylolisthesis. So you can actually see here the L4 body is slipping forwards over the L5 body, L4, L5. So basically you can see on the right side diagram, there's a structure called pars interarticularis, which is the main bone, which actually supports the adjacent facet joints and prevents them from riding on each other. So in young people, it is usually a congenital deficit in the formation of the spine. So they actually manifest with back pain in their primary school or even the secondary school. And they usually grow up with lower back pain. But most of the times they actually hesitate to report this lower back pain because they think that there is a sign of sickness, so they would rather cope. And surprisingly, they actually grow with this back pain without any neurological deficits, even though you expect them to have some sort of deficits. But very rarely they can actually develop neurological symptoms as well. So it is usually diagnosed in the 20s or early 30s. So that is of congenital type. But there is another one which is actually called a degenerative listhesis, which is usually due to degenerative changes affecting or weakening the pars interarticularis bone, and that can actually lead to a very gradual slip. This is very commonly seen after the age of 60, 65, and more commonly you see these days in elderly people around 75, 80 years of age, because people are living longer, and when they develop neurological symptoms, and that's what we see them. So this is one of the most common, second most common condition for lower back pain. So moving to the next slide, what we call a spinal stenosis. So spinal stenosis is nothing but a narrowing of the spinal canal due to hypertrophy of the facet joints, and as well as there's a degenerative disc osteophyte. So the space available for the chordae equina is quite narrowed. So the nerves exiting at that level are also compressed because of the foramen stenosis, and there's no space available for the chordae equina, hence because of the lateral stenosis. And also there's a facet joint arthropathy, and that leads to hypertrophied facet joint as well as ligamentum flavum. So the combination of this is going to cause a severe back pain. Typically, the symptom starts in the early morning. The people get out of their beds with a severe back pain, which they describe as a very stiffness. And after a couple of hours, when they start moving around, then the pain usually gets eased off. And then the clinical symptoms are, they normally start walking normally. Then after walking for some time, depends upon the degree of stenosis, and then they get pain or numbness or tingling sensations in both legs, and sometimes in one leg. And then they have to stop to get rid of the symptoms. Maybe that is like 10-15 minutes, and then they have to start back again, only to repeat the story again. And typically, all these patients are elderly patients, because this is usually caused by degeneration. Again, in a very, very small group of young people, also they can develop spinal stenosis, and that is due to a congenitally narrow spinal canal. And that typically they are between 20 to 30 years of age. So which is very, very uncommon. And the other hallmark of presentation of spinal stenosis is in the history itself, they'll tell you that when they actually go to supermarket, they actually look for a trolley, and they have to lean onto the trolley to just get some pain relief in the legs. So which you can actually understand the biomechanics of lumbar spine. So when they actually flex forward flexion of the lumbar spine, which leads to opening up of the posterior elements and creates a bit more room for the nerves. So they actually adjust their posture to get that symptom relief in order to carry on. So this is a very classical presentation, and it's a classical demographic groups actually. So the next one is going to be the spinal infection. So I put as rare. It is actually not that rare. The reason I put rare is I don't want people to suspect infection in the spine, because they come with some other inflammatory what we call symptoms. So, but you had to suspect infection in the spine if they have some risk factors. Like, for example, in this country, immunosuppression, diabetes, or people are on drug addicts, intravenous drug abusers, or people are on with some cancers, or they have some open wounds because of the trauma which got infected, or they have some other predispositions to have sepsis, that kind of stuff. Otherwise, it is very uncommon. So typically, these patients can develop infection secondary to some foci of sepsis somewhere. The most common could be urinary sepsis, or could be a respiratory tract infection. The spread to the spinal cord is usually heterogeneous. And if you just recall the anatomy of the venous drainage of pelvis and pelvic viscera, and it's usually due to the through the Batson venous plexus, which actually connects to the epidural veins. So any focus of sepsis within the pelvis, both in men as well as in women, can actually lead to sepsis spreading into the spine, and that can lead to spinal cord spinal epidural abscess. And in some people, especially in the intravenous drug abuses, the infection can actually go through the venous system of the upper limbs and they can actually go to the cervical spine or maybe cervicothoracic area. So this is the typical presentation. So unless you know the background history and the risk factors, you cannot actually suspect spinal epidural abscess. And also the presentation can be sometimes very acute, like they can actually present with a rapidly progressing quadriparesis if it is a cervical spinal infection, or a paraparesis if it is a thoracolumbar infection. But in some cases, this could be a chronic as well, especially if the patients develop a tuberculous infection, so which is definitely uncommon in this country. But I think it depends upon which part of the country you live in, and you do get tuberculosis as well. So you have to keep that as a differential, especially if you're seeing people coming from abroad. So that is in fact that is infection. So you can actually see here, it can actually manifest as a space-occupying lesion, which is an abscess, most commonly epidural, because that's what the veins are, and it can actually cause pressure on the spinal cord, give myelopathic symptoms, or it can cause pressure on the nerve roots, so patient can have myeloradiculopathy. But sometimes what is interesting is the neurology of the patients are quite profound, but you don't see much compression in the spinal cord. And that is because the infection actually causes a thrombophlebitis of the the spinal cord itself. So there's a venous obstruction, and hence there's a cord edema. So there's a profound neurological dysfunction and a neurology, but you actually don't see much on the scan to operate. So that's why you should be very wary and mindful that not every time you see a collection, it is so trivial and so small that a major operation to evacuate is not going to reverse the neurology. It's better to avoid an operation and treat with antibiotics aggressively. So that is the story of infection. And we will move to the cancers. I think we are actually seeing more common cancers than the infections in this country, actually, for a variety of reasons. So this is usually, again, the most common cancers that actually spread to the spine are the prostate in men, and the gastrointestinal tract malignancies, and very rarely any malignancies that is in the lymphoreticulaire system, and also the other malignancies affecting the respiratory system, etc. So typically the patients will have a history of cancer, and then they usually come with a mechanical back pain, and which can be usually ignored in the initial stages. But the pain
Mr.
is,
Hussain, sorry,
hello.
can I just double check which side you're on? Because I'm not sure if we're on the same slide. I'm on slide 11 at the moment. I think that's the one that's being shared with everyone.
Yeah, I'm on the slide 11 as well.
Okay, no, that's perfect. Thank you.
Yeah. So the pain from the cancers is usually a very constant pain, unlike a mechanical pain. So with or without activity of the spine, the pain is more or less constant. And also the pain actually is worse when you don't use the spine, like a degenerate spine. But because they got underlying malignancy, so it actually affects all the elements of the spine, both soft tissues as well as the bony elements, and pain is out of proportionately severe. And typically the pain is worse at night. Like most of the pathologies, the pain is worse at night. So that's what it is. And depending upon the involvement of the neural structures, and the patients can actually have neurological symptoms as well. But to begin with, they usually have only back pain. But again, you have to be very mindful of the history, because cancer back pains usually will have a very short history, and it's quite rapidly progressive, unlike a degenerate spine lower back pain, which is quite chronic, and it has got a history of relapse and remissions. But the cancer pain, once it starts, it's actually quite short history, and it's quite intense, and it is rapidly progressive. So I'm now on slide 12, yeah. So coming to the diagnosis and management, the good old the acronym is Socrates. So I think we're all familiar with that. So basically, I would like to divide the lower back pain just for the sake of a triage and to understand the management plan moving forwards into acute, subacute, and chronic. So this is actually there is no scientific basis for this. This is just purely clinical grounds. So any pain that is less than 6 weeks is acute. So in the most common causes for acute low back pain is either you have a disc herniation or a trauma of some sort, or some sort of an infection rapidly progressing. So subacute is usually between 6 to 12 weeks. Again, it could be the same conditions, but again, it is not of that severe type. And typically the chronic ones are more than 3 weeks, and you see in a very gradually evolving lower back pain, and usually due to degenerate conditions. So I think it helps to understand. I mean, I think the golden principle in managing the back pain is any pain that is acute and rapidly progressing needs an urgent attention, and anything that is subacute or chronic can wait. So that actually is the most important message. Otherwise, all these patients will be heading towards A&E for nothing. In terms of I just put some of the neurological, the nerve roots which affect the various parts of the limb, but this is just I don't want to repeat because they're all pretty basic. I think this slide was for medical students. So in terms of examination, I think the positive straight leg raising test is very important to diagnose the pathologies affecting the sciatica, not necessarily a disc, but it can be anything that is actually causing compression of the lumbosacral nerve roots. So what it means basically is patient should be able to lift the leg straight without bending the knee off the bed, and anything less than 30 degrees is considered to be positive, because that's what is going to put what we call the stretch on the sciatic nerve, evokes the pain. But anything beyond that is not. So that's very important. And the lower the the angle of elevation, and more significant it is clinically. And sometimes if the disc herniation has caused a sequestrated fragment within the spinal canal and catching the other opposite nerve, and patients can actually have pain in the opposite limb when you actually raise the ipsilateral limb as well. And to diagnose the pressure on the higher lumbar nerve roots from L2, L3, L4, then probably you have to do the reverse test, which is called a femoral stretch test, which is basically the patient is lying on the tummy and you're actually extending the hip so that the femoral nerve is stretched. So which most of the times we don't do, but the patients will typically tell you that they can't lie on their on the tummy, and you can actually suspect that's what it is. But sometimes you also see a similar symptom if the disc herniation has gone intradural as well. So this is a very atypical symptom, but it will tell you where the pathology is and what kind of pathology to expect. I think patients can actually come with back pain, but they can also have other symptoms which they may not be able to complain unless we suspect, or we and then we ask those questions. So one thing one should not miss is the cardiac venous syndrome, which everybody's really afraid of, right from the GPs to neurosurgeons to A&E, the trauma orthopedics, including the patients. So I think that's why I just put in the boards that I think I'll spend a little bit of time on discussing the cardiac venous syndrome a bit further. And one should also should not miss the cancer of the spine as well, because sometimes you have metastatic deposits in the spine with indolent cancers without actually much symptomatic primaries. Sometimes you have cancers of unknown origin. So, and that's what the first presentation could be just a metastatic deposit in the spine as well. And we do see actually more patients these days without a known primary. So that is something that we can't afford to miss, because these people will have a diagnosis if we actually suspect and do a biopsy under CT guidance, and we can actually get a diagnosis and a treatment for that. So spinal infection, as I said, we can't afford to miss it, because this is potentially a treatable condition by surgery within 24 to 48 hours, or even with a broad spectrum antibiotics. And most of the times the recovery is going to be almost like near normal. So one cannot afford to miss spinal infections. And then the spinal fractures, especially the stress fractures in elderly people, they can actually come with an acute lower back pain or a mid-thoracic pain because they've got a osteoporotic fracture of the vertebra. And if you can diagnose them fairly early, and we can monitor them, and the subsequent X-rays, if they show there's a progressive decrease in the height of the vertebra, and that leads to worsening of the back pain. So there is a role, especially for vertebroplasty. We can inject a cement into the vertebra and stabilize the fracture and prevent further collapse, and actually give good pain relief as well. So there's a lot of evidence now evolving in the literature as well. So the other thing is simple back pain sometimes can lead to cord compression. I think we have seen a couple of slides. So I think examination is very important. People will not be able to tell you because their walking is limited. We think it's all because of the back pain, but unless you examine, probably will not be able to identify myelopathic symptoms or myelopathic signs. So any back pain, I think a basic neurological examination is very crucial to make sure that there is no evidence of cord compression. So cord compression means there's a impending problem that is potentially treatable or reversible. So just to make sure that they examine the patients. And sometimes we get locked into only neurological conditions or orthopedic conditions for lower back pain. But it's always good to think outside the box because at least I remember a few cases that I diagnosed which are actually not neurosurgical, but they're actually general surgical, including a gallstone. So I think it's always good to think outside the box, and other conditions which can actually present like an acute or chronic lower back pain, but they actually got a problem in other conditions. So I think the most common is the peptic ulcer and pancreatitis. So this typically comes like a mid-scapular pain in between the shoulder blades, which can actually mimic C6, C7 radiculopathy. And the genitourinary causes are the kidney stones, pyelonephritis, prostatic and pelvic infections. So these typically come with an upper lumbar spine pain, which can radiate into the flanks or into the groin. So which can actually mimic as a L1 to L5 radiculopathy as well. And patients with ankylosing spondylitis, they actually got a diffuse spinal pain affecting the entire spine, and they have a typical history, strong history. And the presentation is very early, less than 40 years old, and most commonly men of that age. And then typically the pain is at night, which is not relieved when the patients actually take supine position, because it actually makes them worse. So they are curled up in their bed due to pain. And that's a very important piece of history. And morning stiffness relieved with movement is not typical of ankylosing spondylitis, because that you see in every degenerative condition. But most important differentiating factor is going to be the age and as well as the pain profile. The pain is out of proportionate to what you see on the scan, unless you clinically suspect. And also the age of the patients are younger patients, and also usually males are affected in this condition. And osteoporosis, so that is another risk factor. And this can happen in both young people and old people. In young people, most common is going to be the alcohol abuse. And in some people, due to hormone imbalance and other endocrine disorders. And in typical old people, both men and women, and they can get osteoporosis. And then they usually manifest with either a chronic spinal pain, or if they had a recent osteoporotic fracture of the vertebra, they can actually present with an acute back pain, depending upon which vertebra got fractured. And very rarely, you can actually get shingles, which can actually give a very severe back pain as part of the myalgic syndrome. So, and I put the last one in a little bit bold because we have been caught up a couple of times in neurosurgery. People with the ruptured or dissecting AAA can actually present with a very stabbing lower back pain or maybe mid-thoracic pain. And very rarely, I think I remember one patient in Wales, he actually presented with a fairly acute onset of paraplegia, because he dropped his blood pressure so low after dissecting the aortic aneurysm that the spinal cord perfusion got compromised. So he lost his power in both legs. And that is something that we have to keep in mind as well as one of the differentials. So I think one of the important questions we always ask is when to refer a patient with a back pain to a tertiary care center, maybe orthopedics or maybe a neurosurgery, depending upon the service model in that area. I think always keep in mind that we should never miss red flag symptoms in the history. And if you got any of the symptoms, then definitely feel free or have a low threshold to refer to the nearest tertiary care center. So the neurological features of chronic venous syndrome, which is basically worsening lower back pain, which radiates to both legs, and you got the numbness around the genitalia and difficulty in passing urine, which could be a hesitancy, or it could be a bladder retention, or it could be retention overflow incontinence. And occasionally you can actually get even bowel incontinence as well. So if you got any one of those symptoms, don't assume that this could be this could be that, but just give the best benefit to the patient by referring at the earliest opportunity. And if you suspect any serious spinal pathology, such as recently very acute onset of lower back pain with a rapidly evolving or worsening lower back pain with some neurology, then as I said, the shorter the duration, the more urgent is the referral has to go. And that's a very important bit one should not forget. And also, if the patient develop any progressive neurological deficit, like a weakness, anesthesia, then this requires urgent referral to rule out a surgical lesion that is gradually expanding within the spinal cord. So this could be a tumor, or this could be a chronic condition that has reached a critical point of decomposition. So that definitely needs what we call attention and investigation. So any nerve root pain, which is not resolving after 6 weeks, needs to be referred. But again, this is not that urgent as the literature describes, because we got the pain pathway, so we got other means of evaluating these patients. But I think this is not that important these days, because we got neuropathic agents, a lot of drugs, and the nerve root blocks. So we don't need to see a surgeon with unrelenting nerve root pain for more than 6 weeks. So patients with what we call ankylosing spondylitis, so if they actually complain of any back pain, I think you have to be very quick in referring these patients to rheumatologists as well as neurosurgeons. The reason is these patients are at risk of spinal fractures. And if they fracture one part of the spine, it is usually common to have a fracture at the adjacent level of the spine as well. So they usually have 1 or 2 fractures in the entire spine. And the very unique feature of these fractures are they usually affect all the 3 columns, and then the patients can actually have an unstable spine, and then they can actually become paraplegic or quadriplegic depending upon where the fracture happened. So if you know that this patient got a history of ankylosing spondylosis and he got a back pain, so put him in the bed rest and get imaging, even if it is an X-ray, to make sure that the fracture has been ruled out. So this is something that I think in the community, all of you guys, when you deal with the patients with the ANG-SPON, make sure that you don't miss spinal fractures, because we do get some referrals from some areas, patients presenting a bit late, but they already got the fractures, and then it's actually quite unstable. So if they got to neurology, then it's going to be difficult to reverse it. And because of the bone quality, even if they need an operation, they need quite an extensive operation to stabilize that small segment fractures. So the early diagnosis, early referral is paramount in these patients. So I was actually looking into some of the what we call information on while I was preparing for this talk. So what I found in the Keele universities, they actually got a video in their website, which is actually in the public domain. I think I asked Mel to put the link in the for you to access in the message box. So basically, if anybody presents with a lower back pain, especially non-specific, so they would just want to risk assess this patient and stratify them into mild, moderate, and severe type. And they use the A*T back, which is I think people can actually, I couldn't play the video here, so probably you can watch the video a bit later. So they usually take the history, and then they categorize the patients into 3 categories, which actually helps them to what we call they tailor the management as well. So the most important steps in the management is basically a self-management advice. So which basically you talk through the patient, you assess the precipitating relieving factors, and also you check with the patient about his lifestyle and what he wants to do, what his expectations are. So then you just give them the advice how to manage, how to avoid a few things, and how to improve the core strength and back muscle strength, and what activities can be considered to improve their lifestyle and that kind of stuff. So that actually works in majority of the patients, especially the back pain is non-specific in nature. And then the next option would be to treat the pain with a non-pharmacological treatment. so without actually interfering with any what we call strong medications. So it is usually helpful in patients with a subacute or chronic pain. So it is one of the options is the CBT, the cognitive behavioral therapy. I think it's more or less like a self-management advice. But again, you get to understand the patient's psychological condition and its psychological reaction to the pain that he's going through. So I think if you just address that part of it, then their perception to pain is going to be altered, and that will actually help them better to cope as well. And there are some exercises you can teach to strengthen the muscles, be it the neck pain or lower back pain. So, and then you can actually give them some information, leaflets, and signpost them to watch some videos. I think that's also very useful for them. And then I think there are some colleagues from chiropractor. They offer some spinal manipulation, and most of the patients do feel comfortable, and actually they feel better avoiding a consultation with a neurosurgeon or an orthopedic surgeon. So that is also very helpful. And sometimes the multidisciplinary approach as well, because all people get involved, like the physiotherapist, the pain specialist, the chiropractor in the community, and they can actually have an integrated approach that also is very helpful to the patient as well. I think there's a little bit of evidence to suggest that if the pain is acute, and people do recommend some superficial heat, but I don't want to stress on this too much, because there are some patients that I have seen in my clinic. They actually got some skin burns because they were using the heat patches too much, and obviously they get some pain relief, but they didn't realize that there's a superficial skin damage by applying heat. So I think alternatively, you may want to use some infrared heat, which is less harmful to the skin rather than the hot water bottles. So coming to the pharmacological options, typically the patients start treating themselves before seeing the GP is the non-steroidal anti-inflammatory drugs, which they buy from the counter, including paracetamol. And if it doesn't help, then they try various things before they actually see a doctor. So we will come to what we call the specific medications at a later stage. I think I should have a slide at some point. But try not to encourage them to go for these medications without a valid reason, because there are a lot of adverse reactions to these medications. And these medications, if they are continued for longer duration, they can actually have the deleterious effects on the gastrointestinal system as well as the kidneys and everything. So, including the clotting parameters. So, try to discourage them from taking these medications in the long term. So with regard to management of a nerve root pain, which is usually a pain going along the single or double nerve roots affecting one particular limb. So it should be initially treated like a simple back pain with analgesics. And if it is severe, then it's not actually settling, it's actually getting worse. Then you can actually see a GP for an examination to confirm the diagnosis, and also to make a decision whether he needs any imaging or a referral to neurosurgery or orthopedics. So I think the step one should always be just to treat with medication to start with. If the pain is not resolving, there's no timeline like 4 to 6 weeks. For example, even if, it is like 2 weeks, he can always come to A&E, especially if the pain is too much, affecting his lifestyle. And sometimes in that severe pain, they can actually go into a reflex bladder retention or overflow incontinence. So I think it's always good to, if the GPs are unable to see them for any other reasons, I would encourage them to come to A&E and have an opinion from one of the doctors as well. So so I just want to elaborate a few things. This is quite an exhaustive report, nearly 100 pages. So I just picked up a few important bits for this talk. So they have actually, the GIRFT, they submitted a program National Specialty Report in 2019. And this report is basically about the management of lower back pain and radicular pain. So this is basically, we are trying to collect the data across all the hospitals in the NHS in England, and so that they actually understand the variable practices of managing these conditions across the board between different specialties as well, like rheumatologists, the orthopedics, and then the neurosurgeons. And they're trying to standardize the approach to managing these conditions based upon the evidence, and that's what they're trying to do. So what they found in this report is nearly 5.7% of the patients receive 3 or more facet joint injections within 12 months of their diagnosis as back pain, and there's no evidence to support this. And this has been going on in the NHS for a very long time, and there's no evidence to support this. But still, this practice is still happening in the NHS, especially in those hospitals where there's no spine surgery services. So the cost of repeating injections is around 10.5 million in the NHS England hospitals. And then you see the highest rates of injections in those trusts where there's no spine surgery services, but there are pain services available. And I think when it is, I think, is reasonably justifiable if the patients come to that hospital, they need some pain relief, and that's what they get it. But what they're saying is there's no evidence, so I think we should refrain from such practices. And what they recommended basically is every CCG has to work with the local trust to agree and implement national lower back and radicular pain pathway, so which is actually quite a big pathway, which I didn't actually put here. You guys can actually refer that one. So what it is basically is an evidence-based approach to manage lower back pain and radicular pain. So the working arrangement for that local hospital, depending upon the demographics of the population, and then the amount of back pain patients and the amount of the radicular pain patients referred to that particular unit. So they have to actually evolve a working strategy and approaching these patients in a very cost-effective, evidence-based manner, and that's what it is. So that's what they recommended, because there's no uniform approach across the nation, but they said you need to evolve your local policies, working in partnership with the CCGs. So what they recommended basically is decommission facet joint injections in all the hospitals. So which hasn't happened, but it is working in progress, because it is still being offered by the orthopedic surgeons, not by neurosurgeons anymore. It is not funded anymore for neurosurgery. So, and then again, they strongly recommended that we should actually commission a diagnostic medial branch block. But again, don't repeat it. It's only diagnostic, so it's only one injection, but do not repeat. But some of the pain specialists and our anesthetic colleagues, they tend to repeat more than a couple of times, or 3 or 4 times. So it has no diagnostic, there's no therapeutic or diagnostic value beyond one injection. So I think what they recommend is we can only commission, they only pay for one injection if it's only for diagnostic purpose, not for therapeutic purpose. So this is again not followed across the board still. And you can repeat facet joint denervation at 12 months if the patient actually reports there's a significant improvement in the pain relief as well as the functional outcome. So it should be patient-driven rather than you proposing as an option to the patient. So if he says, after that injection, I had a very good pain relief and my function has improved significantly, then probably you can actually offer that. But again, there's a reliability issue here, because the patients can actually trick the pain specialist or the doctor for the second injection, so which may be again not the best way to manage. So radicular pain injections are only repeated if at 6 months, if the patient says he got a good pain relief and function. So with regard to injection, I think the funding is only for 2 times in a year. But as most of you are aware, that the nerve root injections in some patients don't even touch the pain, and in some patients it gives pain relief maybe for a week or 2 at the most. So by 6 months, I think they're asking for a 3rd injection actually, so which is not practical. Again, they recommended that anybody who needs a neuromodulation, especially the chronic pain patients, so the spinal cord stimulator is an option, but that has to be discussed in the pain MDT, which means we have to evolve and change what we call our working pattern and involve a multidisciplinary specialist from the neurosurgeons, the rheumatologist, the pain doctors, as well as the neurologist with the pain interest, as well as the anesthetist with the pain interest. So we need to involve these guys. So that the decision to insert a spinal cord stimulator, which itself is costing around £20,000. So it has to be through the MDT decisions. So I think that is mandatory, which means, in those days, the two surgeons making a decision to insert SCS are gone now. So we can't do that anymore. according to the GRIFT recommendations. So with regard to the Cauda-Equina syndrome recommendations from the GRIFT, so what they have done basically is they discussed this with all the stakeholders, and there are combined guidelines issued by the SBNS, Society of British Neurosurgeons Society, as well as the British Association of Spine Surgeons Society. So these two people actually have seen the recommendations, and they actually agreed on some of the principles which will guide to manage patients presenting with the Cauda-Equina syndrome in the local hospital or in the tertiary care centers. So one of the most important cornerstones of these recommendations is accessing an emergency MRI scanner. So any hospital which has got MRI scan machine are obliged to offer the MRI scan service to the patient presenting to their A&E with the Cauda-Equina syndrome. That is the bottom line. So the reliability of clinical diagnosis is often threatened, or actual Cauda-Equina is low, and there should be a low threshold for investigation for an emergency MRI scan at the request of the examining clinician, and the MRI scan must be available at the referring hospital 24/7. So this is not happening in practice, but that's what their strongest recommendation is. And in fact, the trust are strongly encouraged to look into this, how they can fund a 24/7 service for an MRI scan. So this is a big problem. I think there are sometimes either you miss the diagnosis, or you delay the diagnosis, or you end up in sending the patient to the next hospital for an MRI scan. Either they end up in having a diagnosis and treatment, or if not, they're going to come back. So it just causes a lot of logistic problems. So this is something that the GRIFT is quite keen for trust to work towards. So the decision to perform an MRI scan does not require a discussion with the local spinal services. This is something that, again, I want to send this message, because sometimes people will wait for a neurosurgeon or an orthopedic surgeon to advise you for an MRI scan. But if you, as a clinician, have a suspicion in the referring hospital that the patient actually got some sort of a Cauda-Equina syndrome features, either impending or full-blown, then just do an MRI scan. So you don't need to, because sometimes it takes a long time to get hold of us. Calling through switch, blips are not being answered, you're on the line forever, and that actually delays. And even if you document that particular delay, you cannot protect yourself, because you actually got the MRI scan in your own hospital. So I think that's what they wanted to make it very clear, that you should actually perform the MRI scan. You don't need to wait for any discussions. Then the MRI scan must be undertaken as an emergency in the patient's local hospital, and a diagnosis achieved prior to any discussion with the spinal services, which means you should have a positive MRI scan report to call the surgeon, either orthopedic or neurosurgeon. So you cannot be calling him without the evidence on the MRI scan that the patient actually got a surgical lesion that needs an operation. So that is actually made very clear. So the next one is going to be the MRI scan must take precedence over routine cases. For example, they booked 4 routine cases for MRI scan. I think they should be able to cancel one case and accommodate this impending Cauda-Equina patient in that list, rather than saying that these patients are already booked, they are coming, we can't, there is no slot. This is what most of the times we hear. So these are all agreed protocols, actually agreed arrangement at the national level by these two highest bodies. And this is the evidence most of the lawyers will be using to argue against challenge the trust as well. So I think we should be very careful about these things. And any reasons for the delay or a decision not to perform an emergency scan should be clearly documented as well. So I think the documentation actually saves the reputation and the cost for the trust if it is if it's a proper documentation with a proper explanation. So I think now the trust lawyers are actually encouraging all doctors to document very clearly why the MRI scan was not performed. Whatever reason, just document. If you don't document that, that shows a very bad behavior. So if the MRI scan is contraindicated, then obviously you need to have. Sorry, I can't see the bottom of the slide here. Am I missing something here?
Sorry, no.
Can you hear me?
Yeah, sorry, Mr. Hussain. I was just checking over the slides. So the last thing on the slide that I can see is if MRI is contraindicated
And discuss with the local spinal services, is it?
Yes, so that's on my
Okay,
slide.
yeah, if the patient got a situation, a medical condition where he can't have an MRI scan, for example, he got a metallic heart valve or he got a pacemaker, and you're not sure about the pacemaker's compatibility with the MRI scan, then definitely that's a condition where you can actually speak to us, and then we can actually find a way to do it. Either we ask for more information, or sometimes if it's urgent, then probably we have to go for a CT myelogram to rule out a cardiac venogram. Because these days we are not performing the simple myelogram, so it has to be a CT myelogram. So these are the points I just want you to be aware, because these are all discussed between the SBNS and BAS. So because this is a nationally agreed arrangement, and this slide is used as evidence by the lawyers to argue against the trust. So there's another national audit, what we call NTICE, which is evaluation of national treatment and investigation of cardiac vena. So this is an audit which is quite interesting. So what they found basically is around 23% of litigations claims are related to cardiac vena syndrome in the NHS litigation authority data. And also 63% referrals made without MRI scan. So which is quite interesting. That's the reason why they said all these referrals have to be made to the hospitals after the MRI scan. So 23% transferred to emergency spinal units. So I think these are the very important numbers. And then another interesting piece of data in this audit is the median time to MRI scan, which is usually 4 hours if the patient is referred from another specialty within this same hospital, same unit. So for example, we got a Coventry hospital and we have got neurosurgery and we got a medical ward. So the patient on the medical ward got a cardiac vena syndrome suspected, and we got an MRI scan, it takes roughly around 4 hours. That's what it means. And then if the patient is transferred from an outside hospital to our hospital, the average time is around 7.2. I'm just giving an example there. So the median time, if the patient is actually transferred from other hospital, and we tell them, okay, fine, you can't come, can you just do the MRI scan in Warwick and call us back? So it will take 13.3 hours for them to do an MRI scan in Warwick, and then by the time they call us back. So if you look at this timelines, is very important. How much delays we are actually causing because of non-availability of MRI services or communication gaps or other factors. So it's very important to understand that do the MRI scan if possible within your hospital, and then ring the doctor if there is a surgical lesion. So I think they found this in the national audit. So I think based upon this only the recommendations came out. So any significant referrals they found is a bulk of it actually made during out of hours or even nights, because these patients were actually admitted somewhere in the morning and they actually made a diagnosis, and probably the MRI scan was not done for some other reason, or the MRI scan was done, and then the SHOs or the junior doctors were doing more urgent things in the ward, and then they kept all the referrals as part of the general referrals to be made in the evenings. So they are calling the neurosurgeons or orthopedic surgeons to look at the scans, the brain scan, thoracic subdural, that kind of stuff. So they're actually mixing these things as part of the bulk of referrals, which they normally deal after 2 o'clock or 3 o'clock. So by the time you see what you call a referral, it will be like 4:35 o'clock, and the patient actually see the history. The patient actually has been there for maybe more than 12 hours, maybe 24 hours, and he had the scan during the day as well. So people actually don't understand the urgency of the situation purely because of the kind of work we do in hospital settings. So they found that the significant referral bulk was actually made out of hours and nights. So I'll show you some more interesting slides, Kurt, about this condition. So it is not actually a topic like people think. It's actually quite a big field by itself, and the people actually made some careers managing the litigations around cardiac vena, both the doctors writing the medical reports as well as the lawyers fighting the trust. So I think most important point I would like to summarize about cardiac vena syndrome is it is actually got a very variable presentation. Not every patient presents in the same description like you see in the textbooks. So one should be very vigilant and suspicious of the presentation, and you should have a low threshold to suspect and diagnose cardiac vena. That's a very important approach. No single sign or symptom can be justified on rationing an urgent MRI scan. So you can't say, oh, he does not have incontinence, He does not have a perianal sensation. His tone is, I think it is fairly normal. So there's nothing like that. So if you got a diagnosis, if you've got a suspicion, just do an MRI scan, because the examination findings are, again, there's a variation between people who examine the patient. It all depends upon the experience of the person as well. So, and then the interpretation. So there are a lot of variations there. So that's why if you suspect, just to do it, don't ration it. And the neurosurgeons aren't the gatekeepers for MRI scan vetting. So there's a lot of misunderstanding in the system that we actually control the MRI scan machines in our hospitals. And if you speak to neurosurgeons, it will happen very, very quickly. No, that's not the case, because we actually have no control on the MRI scanner at all. So the patient symptoms is the one that actually drives the whole system. So no excuse for failure to documentation for delays in management. So this is something that the lawyers will love it. Sorry. So any delays from for any reasons, it has to be documented very clearly. And I'm aware of a few cases in our trust where we actually paid huge sums because of the non-documentation or poor documentation, which we could not defend when the lawyers actually challenged. So the evidence also suggests early surgery offers better outcomes. But what is early surgery? And there's no actually evidence-based timeline. So I think the in general principle is, as soon as you know that there's a patient with cardiac vena, do the scan, rule out a surgical lesion. If you find one, operate at the earliest opportunity. I think that's the best approach to do it, and that's what most of the surgeons, most of the hospitals offer. And then also you find sometimes risk of operating overnight is contrary to CPOT papers, because you do see some surgeons pretending that, oh, this is what do you call, in the middle of the night. There'll be a staff who are not well trained, and there's a logistic issues here. There's a problem with the team members, and there is a more risk with the operation. So probably it's best to do first thing in the morning. So that is completely opposite to the evidence that you have in the CPOT papers, because the CPOT works on the principle of life or limb-saving procedures, and this is actually a limb-saving procedure. So, I mean, if you just defer surgery during the night for a patient who got a full-blown cardiac vena, the trust cannot defend that. I think I just want to simplify the take-home message. I think maybe I got another slide to it's basically lower back pain and radicular pain is managed conservatively, which is almost like 85 to 90% of the times. So that is reassuring for all of us. We don't need to rush to do anything urgent. And also, most important thing is educate the patient with regard to the red flags of cardiac vena. Every patient who comes with the cardiac vena, and or with a back pain, sorry, and they can actually progress to radiculopathy, and they can actually develop a cardiac venous. I mean, in just a matter of time, maybe a couple of weeks, 3 weeks down the line, especially if there's a disc herniation is in progress. So if it's only purely a facet joint pain, and that's a different story. But I think it's good for every patient with a back pain to know when to come to hospital and what are the red flags of cardiac vena. So that actually helps them to reassure as well. And always encourage every patient to return to work ASAP, because there's a strong evidence, both in the European as well as in the American literature, that the people who return to work or who are actually in work with back pain, they have better outcomes in terms of a functional recovery rather than those people who don't. So there's always a pressure, especially on the doctors, both in the community as well as in the hospitals, to give them some sick leave, and also to extend the sick leave for some more time because of the ongoing back pain. So those are the type of patients, or that particular cohort of the patients. So they actually end up in disability allowances and benefits, and they actually lose motivation to work. So always try to encourage them to work as much as possible, including what we call recommendations to amend their job plans, or change the duties, or maybe retrain in different skills. Some sort of, they need to be working. Otherwise, loss of work or unemployment actually contributes more to their problem. So that's very important. I'll also diagnose red flags and refer to local hospital for MRI scan. So never miss any red flags. Red flags are basically worsening low back pain with radiation into both legs, numbness, pins and needles, and loss of sensations around the genital area. And the bladder disturbances can be from hesitancy to increased frequency, to urgency, to nocturnal frequency, to incontinence, or sometimes retention with overflow incontinence. So this is the full spectrum of bladder disturbances. So don't wait for incontinence. So if the patient says, I got an accident, that is a quite a late sign. So bladder is pretty flaccid because it lost the tone altogether. And that's not going to recover even if you operate. So have low threshold to diagnose the red flags. I think we are coming to the end of the talk, and I'm happy to take any questions from you guys.
I have a list of questions for you.
Please.
Right. Is vertebral plasty contraindicated after radiotherapy for metastatic prostate cancer of the cervical spine?
The first thing is, well, I don't know the right or wrong answer, but I can only say from my experience, and I'll let Mr. Joshi comment on that as well. The vertebroplasty procedure is not routinely performed in the cervical spine because the spinal canal is pretty narrow there, and the spinal cord bulk is quite big. So if the cement leaks into the spinal canal, there's a serious risk of causing spinal cord injury. That is one. Number two, in metastatic spine, there is no indication for vertebroplasty unless the kind of cancer has got a very good prognosis and there is good quality of life expected. Because vertebroplasty is basically given, what we call most commonly given in osteoporotic fractures. So where the patients are in good general medical health and they have a fairly good quality of life apart from the spinal pain. So that can be offered. And then the number of levels of vertebroplasty, people have gone up to even 6 vertebrae. And there are some studies where they have gone up to even up to 10 as well. So depending upon what pathology that you are dealing with, I think that's very important. And number two, it is usually offered to thoracolumbar areas rather than in the cervical. Cervical is anatomically, it is not a safe zone for the vertebroplasty cement to go in. So I don't know if that answers the question.
Rahim, I agree with you. In prostatic metastatic after radiotherapy, the jury's out. The vertebroplasty indication is only for pain control. It is not to stabilize or anything. The bone is not light like in osteoporosis there. The bone is already dense over there.
Yeah.
So it doesn't add extra value. But it is for the pain only, and it is the jury's out, and that's why they don't give it.
Yeah.
Okay, another question. Why is ice not recommended for acute back pain? I normally find this works very well for most acute conditions, including acute lower back pain.
Yes, I think. I mean, obviously we are going to be recommending what has been recommended by the NICE or by the evidence. So, as I said, I mean, I can go on some examples of from the patients' stories how they actually got rid of the back pain as well by using different conventional medications. You know, so whatever helps for the patients, if they want to try, they try, and they get rid of the pain. That's fine. So, what we can't recommend is which is not scientifically proven, or it's not there in the NICE recommendations or other scientific forums, and that's what it is. So yes, they can use the ice as well. Certainly, there is no harm in using ice, unlike the hot water bottles, which can damage the skin.
There's also another question along similar lines. Why is physio not recommended for lower back pain?
The physio should be recommended in all fairness. I think the problem is the physiotherapy services are quite inundated and it's difficult to see a physiotherapist. One. Number two, in acute back pain settings, the physiotherapists will not be able to help much because they can't do any physiotherapy with acute pain. So they need to kill the pain for some time before they actually start the physiotherapy. The very purpose of physiotherapy is to keep the joints in motion. So if you've got a painful joint and you can't actually bend the joint, I'm talking about the facet joints. So I think most important is they need a good analgesia and muscle relaxant for a week or two before they actually start going for physiotherapy. And if you start referring every back pain to physiotherapy, I'm sure the physiotherapy services will be inundated with the referrals. So I think that's what they're encouraging if you just to go onto the British Association of Spine Surgeons website. So they actually got some nice information leaflets, how to manage back pain, neck pain, all those stuff. And there's also some there's a diagrams about the exercise, which patients can actually see and do themselves. But they can only do those things if they're fairly comfortable, fairly pain-free.
Right, I'm going to take a deep breath before I start this question because it's quite a long one.
Yeah.
Do you think hospitals that do not have spinal units have difficulty with getting an urgent MRI, perhaps because they don't have as many scanners, neuroradiologists available to them as major trauma centres such as UHCW? This may be an organisational issue rather than delayed diagnosis from the medical team's part.
Yes, I think to just find a balance between such hospitals and then the big hospitals, I think the recommendation is if you got a A&E and if you got an MRI scanner in a hospital and if you're actually accepting a cardiac venous syndrome patients through your doors, the least you could do is to do an MRI scan. And even if you don't have a radiologist on call, which you should have, because that's what they say, look into the design of the service as well. So at least you can do an MRI scan, you can link the MRI scan to neurosurgeons, at least they can have a quick look at it. But even though, according to the, within the law, we're not supposed to be reporting the MRI scans, but we can actually have a quick look at the scan to say, well, there's no disc here, fine, that kind of stuff. So I think that this has to be discussed very closely within the powers of the trust, and they have to design this policy and design the job plans of this radiologist and develop this service. You can't turn away the patients from A&E. That's saying that we don't have an MRI scan, or you can't put the patient in an ambulance and send it to a different hospital for an MRI scan, which is happening at the moment. I think that's what the SBNS and BAS was trying to recommend, that if you got the scanner in your hospital, if it's working, then I think you should do the MRI scan before you actually ring the doctor. You don't need to have you don't have to have a discussion. You don't have to have the recommendation or permission. You just do the scan and then call the spine surgeons. This is quite a complex issue, and it's got a lot of issues around it. The finance, the attitudes, the service model, the job plans, the funding. So a lot of stuff is there. So I think it has to be done in a holistic way.
There's another question here that's just come in. There seems to be a long waiting time to see neurosurgery, especially at UHCW. We're having to advise patients to go privately to try and get some help sooner. When is this likely to change?
Yes, actually, I happen to be the clinical lead in neurosurgery, so I know a little bit of, I investigated this actually very recently. We had a meeting last week. So we actually got some funding allocated to accelerated pathway. So I think they got some special funding from the NHS England. So I think we got the provision now to see long waiters as well as the new patients as an extra patients, either we can see them either in the evenings or over the weekends. So which I just communicated to my colleagues. I think they are all volunteering to see, because obviously there's a funding for new patients. There is a separate funding for the follow-up patients. So we actually got even follow-up patients actually haven't got the follow-up appointments for more than 6 to 8 months. And the new patients are definitely more than much more than that. So I think the priority is now for the new patients, and we got the funding approved. And now I think we are in the process of arranging this extra clinics to see the new patients. So things might slowly get better, hopefully within the next 6 months. I'm not going to be promising on that, but that's what we're looking at. Because we are 9 of us, it's only around 6 or 7 of us are interested to do some extra work. Rest of the people can't for other reasons. So, and also we got some logistic issues as well, because for example, if I want to do a weekend clinic, and I need to find a room, and also I need to find a nurse to run the clinic, because we want to see these patients face to face, because we can't have a virtual telephone consultation for a new patient without examination. So I said, in principle, we can agree for a follow-up patients because we know most of the patients, but still, ideally, we should see them as well, because if we haven't seen them for nearly 6-7 months, and they got some new problems, new symptoms, we would rather see them practically and examine them so that both of us feel reassured and treat them like a new patient, So that's what I'm lobbying for. I think we are coming to some sort of a shape that we should be able to do that And in fact, actually, we started because a lot of colleagues have actually volunteered. They gave their dates for extra clinics. So this might take some time. But we also got some spinal clinics run by a physiotherapist, a spinal physiotherapist. So when we are triaging the GP referrals, we are actually sending some patients with a pure back pain without any neurological symptoms to that clinic, so that she can actually, there's a lady called Lucy, so she can actually evaluate those patients, and if she feels that she needs to be seen by us, she's going to refer back to us. If not, she's going to push them into a spinal back pain pathway for physiotherapy and pain management. So I think we are coming to that kind of arrangement, but with regard to timeline, I think it's difficult because now we are heading to winter now and then the Christmas. So I don't think things are going to be massively changed in the next 2-3 months, but at least there's a beginning. I'm hoping that things are going to move in the right direction, hopefully.
Mr. Joshi, you've got your hand up. Did you want to add something?
Yeah, I wanted to say, if there is no other question, then I just want to add one or two things in continuing with what Mr. Hussain has said.
Yeah, please.
Is there any other questions? Otherwise,
No, there are no further questions.
Okay, just continuing with what Mr. Hussain has said. Headphone off, it will be better, I think. You know, regarding this waiting list, we need to be practical. At any time, the waiting list is not going to get better. Now, a few things are, number one, we should take with a pinch of salt. This accelerated rate and other things are mostly for new patients. You see the new patient, then you still have a problem of follow-up for them. So please take it with a pinch of salt. Mr. Hussain, with due respect, is speaking more from a clinical perspective than from private purpose. Okay, so this is, we see the patient as a new, but you will still have to wait along for the follow-ups. So that's where the problem will come. Okay, so that's one. The second thing I wanted to share was, you know, and it's a brilliant forum with 30 of you there. Most of the patients do not need operation. Most of them don't. Okay, so it's a myth that they go to the surgeon to get operated. And my request to you is, you send the patients to us with a view that they probably will not need an operation, because no news is good news. You can imagine if majority of people with sort of back pain needs operation, what will happen in India and China? You really don't need it. Just because you are in private setting, it doesn't mean you need an operation. But the important thing is to identify when you don't need to operate. And that is the key of a surgeon. And that's why I think it's important that when you send the patient to us, you're not sure it will need an operation, but at least we can help the patient to formulate a plan that you probably don't need and the reasons. And the one classic example I give is, if you have your car, why will you open the engine of your car if you don't need to? If you need to open the engine of your car twice, will you retain that car? You probably will get rid of that car, but you can't get rid of your back. So it's a myth that a back needs an operation. It's actually not true. It might be coming as a surprise to many of you, but that's what it's coming. And we have the skills to reasonably identify who actually not to. The second thing, then I will not say, majority operations don't need metal works, either in the back or the neck also. In the neck, it is to stop the bones from crumbling so the nerves remain free. But actually, in the back pain, the worst thing you can do is to fuse for back pain. And this has been tried and tested many times. Majority of people do not need metal works. The last thing I wanted to say was spinal cord surgery, stimulation. For that, the Coventry has a very good setup of combined pain clinic. It is done for a regional ground, the entire region here. And it's a combined pain clinic, which we run once in 3 months. This is for patients purely for failed back surgery. I don't think I have much to add. Thank you.
Thank you. We probably need to bring the meeting to an end as we've overrun a bit. Did you have something else to say, Mr. Hussain? Sorry.
No, I think I'll just take only 2 minutes. I think I agree with Mr. Joshi, what he said, absolutely. And also with regard to instrumentation, I just want to share my experience as well. So the spinal instrumentation is indicated in a very limited conditions like a trauma or instability due to what we call the malignant deposits. But it's actually, there's no evidence to put the instrumentation for a degenerate spine. And there's a lot of evidence in favor of that as well. So, I mean, that's my understanding after doing this panel fellowship in Wharton, Liverpool as well. So I think you need to give that piece of information to your patients, because patients actually, when they get back pain, waiting to be seen by GPs or doctors, they actually don't keep quiet, but they actually start Googling it and watching some videos and watching these famous surgeons' operations, especially from North America. And then they actually come with an expectation that please refer to me to one of the surgeons in Oxford or in Coventry. We want spinal fixation, that kind of stuff. So probably it'll help for you to simply reassure them. I'm just reiterating what Mr. Joshi said. So there's a very limited indications for spinal instrumentation, and most of the degenerate spines don't need any instrumentation. They just need a decompression. That's it.
Well, thank you very much for your talk tonight. Thank you all for joining us. There is the feedback survey link on screen, and I'll also send it out to you. There's a plea from me for those of you on the call. If you have logged on in a name other than your own, could you please drop me an email so that I know who you are, because there's a few people who just logged on with first name, which I can work out. But if you have logged on with a different name, could you please let me know? But yes, thank you ever so much, Mr. Hussain and Mr. Joshi, for this evening. I will be sending out a copy of the recording and the slides to you all who've attended. So thank you very much for joining us, and I'll let you know when I've got another lecture sorted out.
Thank you, Mel and Vicky, for organizing this. Thank you very much. Thank you, Mr. Joshi.
Thank you, Mel, Vicky. Rahim, that was a very good talk. I learned a lot. Thank you.
Have a good rest of the evening, everybody.
Thank you.
Lovely.
Bye.
Take care.
Bye.
Thanks. Bye-bye.